I am absolutely delighted to introduce our speaker today. Dr. Andrew Quanbeck is an associate professor in the University of Wisconsin's Department of Family Medicine and Community Health. He received his PhD in Industrial and Systems Engineering from the University of Wisconsin-Madison. His research uses systems engineering to innovate approaches to implementing evidence-based practices and focuses on prevention and treatment of substance use disorders. Dr. Quanbeck serves as the chair to the Ochsner Center for Integrative Medicine's Collaborative Research Committee. He is the principal investigator on 4 NIH-funded R01 grants and has authored more than 50 peer-reviewed publications and book chapters. He will be speaking to us today about using digital health to support reduced alcohol use. Please join me in welcoming Dr. Quanbeck.
All right. Good morning, and thank you for that introduction. Thanks again for the invitation to talk with you today. So I was asked by Dr. Kara Hoppe to speak to this group about substance use disorders, and as mentioned, I'm doing research on a number of different areas: alcohol, HIV, opioid use disorder, and chronic pain. But thought I would focus today on sort of research that we're doing on alcohol use disorder and our approaches to using digital health interventions for the treatment of alcohol use disorder, kind of across a broad range of populations and levels of severity. So let me see if I can advance. For some reason, it's not advancing on my screen. Oh, there we go. So I have a couple of disclosures to make. I have shareholder interest in Chess Health, a small business that markets digital health applications to the addiction treatment field. I wanted to mention that I also provide consulting on digital health implementation through the NITEX Foundation, which is a nonprofit consulting organization. The research that I'm going to talk about today really spans a long period of time. Going to feature 2 studies funded by the National Institute on Alcoholism and Alcohol Abuse. The first one started in 2018, and the second one is basically just starting up now. I'm also going to talk about some research from a collaborator, Dr. Linda Park, from our research lab in our department, as we're looking to study alcohol-associated liver disease. So learning objectives. I'm going to talk a little bit about the burden of alcohol use in Wisconsin and at UW Health. Hopefully this is something that we're all somewhat aware of. Wisconsin leads the nation in levels of binge drinking and heavy drinking, and so this is a particularly important issue for our state and for the population that we serve. Talk about how digital health apps could be helpful for reducing alcohol use. Look at a study and results of a study that examines different approaches to supporting digital health app in the clinical setting. And then talk about how the whole health model informs the foundation for alcohol use reduction, both in the general population for patients with alcohol-associated liver disease. So I'm going to kind of talk about 2 or 3 different projects here. That's the result of a lot of work from collaborators who I'm listing here. I'm the principal investigator and senior author on these studies, but it really represents the work of a lot of individuals who've contributed to our research. I'm going to share some slides that were prepared by these contributors that we presented at a conference in New York last fall, and we're continuing to kind of work through as we're getting ready to publish results of some of these studies. We have projects in sort of various stages of development. So I'm going to start out by talking about how we went about adapting an mHealth intervention for alcohol use disorder based on feedback from stakeholders, both within UW Health and within the Madison and the larger Madison community. So the significance of AUD and treatment accessibility. I don't think I need to tell you it's a prevalent issue in the United States and can be associated with all sorts of physical, social, mental health harms, especially with the pandemic. Alcohol use has increased significantly, and we are seeing, in particular, that liver failure among women is really on the rise, and so alcohol is really, it's been a persistent problem in the country, in the world for a long time, but it's really reaching new levels of impact. Just, I think a lot of that is attributable to the rise in alcohol use that started with the pandemic and is continuing, and we're seeing that manifesting in the medical care system with higher rates of liver transplants and liver damage. I'm going to kind of go, talk about a range of interventions and approaches to alcohol use reduction in the primary care setting. Sort of the standard of treatment is screening, brief intervention, referral to treatment. Has a pretty good evidence base, and has shown in studies that it can effectively reduce hazardous drinking. However, the scalability and accessibility are limited. I think as a patient and talking to clinicians, it's sort of not implemented very uniformly or with a lot of fidelity in the primary care setting. So it's a tool out there, but it's not, hasn't been all that effective in solving problems of alcohol use disorder. So as mentioned, I'm a systems engineer by training. In my history, I came from the College of Engineering at UW-Madison. I did my PhD there and worked at a center that was using technology or technologies to treat chronic diseases. And we've done a lot of work with alcohol use disorder. And the idea is that smartphones, which almost everyone has at this point, could potentially help reach people and provide another means to address alcohol use disorder. The system that that we first developed at the College of Engineering is called the Addiction Comprehensive Health Enhancement Support System, or HS. It's if you go back to the history of smartphones, if everyone remembers, the Apple iPhone was introduced in June of 2007, and we were sort of tracking that development. And so by October of 2007, which is basically the first grant cycle after the iPhone came out, we had written our first grant to develop and test a smartphone-based system for alcohol use disorder. That was based on self-determination theory. I'll kind of get into what self-determination theory is all about in a minute here. So self-determination theory says that people have three basic needs: competence, need to have mastery and control over their own lives and their environment; autonomy, the need to feel in control of their behaviors and goals. This is really about not being forced into things, but having choice. And then relatedness. People need to experience a sense of belonging, connection with other people, and feel cared for by others, and to take care of others as well. So this first system that we developed, starting in 2008, I'll just show you kind of what the basic elements are. On the left side, we have a the patient-facing view of the system that would appear on your smartphone. Has discussions, skills training, recovery info. There's a panic button that people could use to reach out if they felt like they were in really at risk of relapsing or heavy drinking. All the data then that the patients or the research participants entered feeds into a dashboard system where a clinician or researcher overseeing all the users on the system can get updates on what they're doing in terms of alcohol and drug use and other factors related to substance use treatment and recovery. So this is David Gustafson, who is my PhD advisor. So in May of 2014, we published the results of our first study of HS. This was done in a population of patients with severe alcohol use disorder who were exiting 90-day residential treatment for severe alcohol use disorder. And we showed a significant reduction, almost 50 to 60% in patients compared to the control group. So this was published in JAMA Psychiatry 2014. Because we were, NIH studies are typically 5 years. We got ours in 2007, got it funded in 2008. This is one of the first reports of a digital health system for chronic disease management that actually showed effectiveness and efficacy in a randomized clinical trial. So this was, a big deal when it came out. And we've sort of been building from this foundation ever since. So, I was interested in, one of the things that happened is I'd present the results of this research at conferences, and there's a lot of interest and excitement, and from healthcare leaders and clinicians, like, well, this sounds really cool. How could I get access to this for my own patients? So we had to think through, like, well, what would it take to implement this at a wider scale and in different settings? And so that's what I've focused a lot of my research career on, is really implementation of digital health technologies and how we can make these promising technologies as useful to patients and clinicians and health systems as possible. So the idea is that, okay, can we take this up to a health system level, and how would we introduce this into a health system? So HS improves drinking outcomes relative to treatment as usual. We weren't sure how applicable HS would be in a primary care population where severe AUD, even if it is present, often isn't identified. And so we knew that we had some work to do to try to make the system work for a primary healthcare system. So we adapted it. I'm going to I'll introduce what we called it. We ended up changing the system and changing the name to Tula, which is a Sanskrit word that means balance, which is, really based in HS, but overcomes some of the potential limitations that might limit its acceptability in a primary health system kind of setting. So we're really looking at focusing on alcohol use reduction and harm reduction, trying to intervene a little bit earlier, before people reach a point where they have severe alcohol use disorder, and address a broad range of concerns among individuals with varying levels of alcohol misuse. So this was done at UW Health, where you're all very familiar with, and we went about working with leaders and clinicians and patients of UW Health to kind of look at the system that we had and get some feedback from them about what it would take to make it work. So we use something called the EPIS framework, stands for Exploration, Preparation, Implementation, and Sustainment. this is a very common framework in the implementation research environment. So basically, in the exploration stage, identify stakeholders to consider what the needs are of the target population. In this case, we had sort of selected HS, but then we had to figure out, okay, what adaptations are we going to need to make for this to work in a primary healthcare population? The preparation phase, we look at barriers and facilitators of implementation and develop implementation plans and strategies. And then in the implementation phase, we ran a clinical trial, which the details of which I will get into, to test the effectiveness of the system on alcohol use. And now we're sort of in a stage now where we're looking at the findings of the study and trying to determine what sustainment might look like within UW Health. It's something that would be, first of all, worth sustaining, and if so, how to go about doing that. So we started out with looking at primary care clinicians and clinic managers, and then did semi-structured interviews with them. We also talked to some IT directors at UW and other potential users of the system. So we talked to potential users from different age brackets, from different racial and ethnic backgrounds, just to get a sense, that how applicable this would be to people with different individual characteristics. And the methods really was about just kind of talking to people and getting their ideas about what we should do. We had so this was written into a grant proposal that was funded, an NIH R01 grant proposal. Our original plans were to integrate data from the app into patients' electronic medical records. In talking to stakeholders really at every level, that was not something that turned out to be desirable or feasible for a number of reasons. We learned that patients really didn't want to have information about their alcohol use in their permanent electronic health record. Likewise, primary care physicians already have a lot of information overload that they deal with and weren't really looking to monitor another, patient's alcohol use as something that they would be responsible for. So we ended up not doing that, which is something that we thought would be essential based on some of our prior assumptions, but that wasn't the way that things turned out. We thought at first that the primary care providers would be sort of the main implementation agents. We learned from talking to primary care providers that alcohol use disorder is a big thing to take on, already very, very overburdened and responsible for a lot of different things. So we looked across the health system and identified health coaches working at the wellness center at the American Center on the east side of Madison, who are already doing this type of work, and we're excited about doing health coaching around alcohol use. I mentioned before that the original HS system was for severe alcohol use disorder and focused strictly on abstinence. We looked going forward to look at harm reduction and not insisting on people being totally absent, but just making positive changes and reducing alcohol use. The models that the original HS were built around, it had to do with recovery. We changed our framework to the whole health model, which is forms the foundation of the health coaching approach that is used at the American Center. And I'll get into more details of what that model looks like. And then, we really thought we'd be recruiting from a couple of different primary care clinics. And for reasons that were both driven in part by COVID and as well as pragmatic reasons, we decided to take more of a broader healthcare system and community outreach approach. So we created 3 new study groups that we would test in the trial. I'll get into details of these, but self-monitoring, peer-supported, and clinically integrated, really designed to kind of look at different levels of or different ways to support use of digital health within a health system with different levels of human support. And I'm just going to kind of briefly go through what, you saw HS before, and now this is what Tula ended up looking like from the patient perspective. The whole health model is centered. The home screen features this circle of health, which has 8 dimensions, including working your body, surroundings, personal development, food and drink, and others. And we sort of oriented the content of the app around the whole health model. We also have this discussion group where people can kind of talk about things that they're doing and encourage each other, built into the app, which is one of the main features of the original HS system. So we did what's called Think Aloud usability testing with 7 potential users who just verbalized thoughts on functionality and design of the app. Then we did what's called near live usability testing with a different group of 5 participants to assess their acceptability of Tula. We found out that we needed to simplify the language in the app. We needed to, think through some of the ways that text could be interpreted based on different cultural contexts. We looked at a wide range of ages to kind of examine the issue of technical literacy. And all of that, helped us refine the app so that it would be more usable for our target population. So we adapted HS and its implementation strategies through exploration and preparation. This process identified stakeholder needs and concerns, and really we spent the first year of our 5-year project in this phase, and I think it just kind of highlights in implementation research the importance of stakeholder engagement, adaptation, and fitting interventions to the context that they're intended for. We think further research is required to explore mHealth implementation for AUD and resource-constrained primary care settings. Again, right now we've just done pre-implementation work. We do plan to talk to people kind of in the next phases to focus more on sustainability. So this is all kind of preparatory to the main event, which is the clinical trial that I'm going to get into now. So I did want to make a quick disclaimer that we have finished collecting data for this study, but we basically have about 2 weeks ago submitted this paper for publication, and it's under review. So just want to make a disclaimer that these results are preliminary, pending the revise and resubmit process. If you want more information on the study details, we did publish the protocol for this project, and you can read about it here. It's in JMIR Research Protocols. So as I said before, this is the Tula app, which I've sort of described already. Getting into the sort of the details of the clinical trial, this is really what the clinical trial was designed to test. So this shows a spectrum, and this comes from an article led by Eric Hermes and others that was published in 2019. It's about, they use the term behavioral intervention technologies, but digital health apps basically falls under that category. So on the left side of the spectrum, you can think of basically traditional healthcare, human delivered interventions, where there's really no role for technology. And that's, the way things have been for most of history, and still in most places is the case. If you go all the way over to the right side of this spectrum, there's the idea of fully automated behavioral intervention technologies. And so the way that I think about that end of the spectrum is that it's really, if you were to download a health app publicly from one of the app stores and used it on your own, which is what a lot of people do, but there's no sharing of data, or there's no role for the app within healthcare. That's kind of the fully automated version of these technologies. Then in the middle, there's sort of gradations of like, okay, how might you integrate behavioral intervention technologies with traditional healthcare? And that's kind of what we're studying within this trial. If you're going to implement this, do you need, what type of support would you provide within a health system to make it as effective as possible? So we wanted to understand how varying levels of human interaction affect the ways in which the mHealth system works. So we developed and tested 3 different mHealth support models. We called the first, the sort of the control strategy, the self-monitored low-touch model, which is basically having individuals use the app without any role for, basically just self-guided use. So like an app like people usually use just on their own. We then had a group that got peer support from a community-based organization. This is that model featured group discussions, peer mentors who would work with a group of individuals. It's kind of like a group-based model for delivering the intervention, but it allows for peer-to-peer interaction and advice from peer mentors. So that's more complicated to implement and costs more, but that's really kind of the way that the original CHESS system operated. And then we had a third group that was more clinically integrated to the extent that we had health coaches working with UW Health provide one-on-one health coaching for individuals who enrolled in the study, so they could get up to 3 1-hour health coaching sessions and really get sort of individual and personalized guidance around using the system and support in reducing goals around alcohol use reduction. So this is it's called a hybrid type 2 implementation effectiveness study. We're also conducting cost effectiveness analysis to kind of understand what is the optimal level of human touch required to implement mHealth most effectively. And our hypotheses basically are that the null hypothesis is that there's no difference between doing this on your own versus group-based support versus one-on-one health coaching. And our alternative hypotheses are that, providing more human support is going to increase the effectiveness of the system. So I kind of touched on this already, but these are the 3 groups: self-monitoring, peer-supported, and clinically integrated. Inclusion criteria, over 21 or over, a desire to reduce alcohol use. People had to own a smartphone and be willing to download and use the Tula app. We didn't provide smartphones for this study, which we have done in some other projects that we've run. People had to live within the UW Health service area, so we could verify through IP addresses if they're coming from geographic areas within the catchment area of UW Health, and then meets the criteria for mild to moderate use of alcohol. So we excluded people who didn't have any sort of non-drinkers or no alcohol use disorder. We also excluded people with severe alcohol use disorder based on the audit screener, which is an 11-question assessment. And I think the cutoff is 6. If you answer yes to 6 or more of the 11 questions, it's severe alcohol use disorder. We didn't think that this system is necessarily appropriate for people with severe alcohol use disorder, just given that it's is kind of promoting harm reduction, where certain individuals get to a point where really should be thinking about abstinence. So this is the consort diagram. We assessed almost 2,300 people for eligibility, and we randomized 558 individuals to these 3 different groups: self-monitoring, peer-supported, and clinically integrated. Just quickly show you the follow-up rates. We did 4 quarterly surveys from 3 to 12 months. We did provide incentives for providing research data. And I think that for those not familiar with the digital health domain, we had very high response rates. If you take kind of the average across all the time points, it's about a 78% response rate, which is quite good for digital health studies, which are known to have very low response rates in general. So this was a rigorously conducted study. One thing you will notice is that the rates of follow-up in the clinically integrated or the health coaching group are significantly lower than they were in the other 2 groups, especially at 12 months, where you're looking at 75% in the self-monitoring, 71% in the peer support, but only 55% in the clinically integrated group. So that's something that we noticed early on, and I think is some important finding in itself of the research. We tried really hard to follow up with people, but the health coaching model is more intensive, and I think it did sort of cause people to drop out at a higher rate. So that's something worth noting. Our primary outcomes are percent of risky drinking days in the last 7 days. Then we looked at quality of life using the PROMIS global physical health and mental health scales. And then, talk about demographics of the population. So this is our analysis plan. Again, I'm not going to get into a lot of details of this. If you're interested, you can read the protocol paper that I referenced previously. I'm going to kind of just show you some of the main results here of what we found. So the study population, I think this is somewhat interestingly was about 2/3 female, and again about 2/3 mild alcohol use disorder, with the remaining 1/3 having moderate alcohol use disorder. Largely white population, kind of reflective of UW Health's overall population. And the other thing to note about the population is that it's quite highly educated. Madison is, I think, the 5th most educated city in the United States, so our population reflects that. And about 2/3 of the individuals were married, and age was kind of middle 40s. So that's what the typical kind of patient looked like. Baseline rates of drinking days were in the range of 37 to 42%. So you might be looking at about 3 days out of 7 of drinking above recommended limits, which would be I think 4 drinks for a female and 5 drinks for a male. And the quality of life scores are a little bit more difficult to interpret, and we'll just kind of focus on the changes in those outcomes over time. So this is the results of the study over 12 months on alcohol on percentage of risky drinking days. As you can see, the alcohol use was reduced significantly, went from about around 40% to around 22% across all the groups over time, representing a significant time effect. However, we didn't see any statistically significant difference between the groups in terms of their levels of alcohol use reduction. The quality of life score is broken down into physical and mental health dimensions. We didn't see any significant difference in physical health. You know, a little bit of a bump in the peer supported group, but not statistically significant. We did see more marked improvements in mental health quality of life with the clinically integrated group showing a significant improvement in mental health quality of life compared to the self-monitoring group. So overall, the group showed lower risky drinking days over time, but we didn't see a difference in the effectiveness between the groups. The clinically integrated group showed improved mental health compared to the self-monitoring group. The one thing that we're kind of looking into with alternative analyses is the extent to which selection bias might play a role in that outcome, because if we had higher differential dropout rate in the health coaching group. So we're examining that through sensitivity analyses in our primary analysis, but that's the intention to treat result that we found. And there was no effect on physical well-being, which I guess over 12 months wasn't enough time for any impact on that. So in terms of the implications, we think, alcohol use was reduced significantly across all groups. The self-guided version is the least expensive and easiest to implement. So we thought it might make sense to provide that to the population and provide an option for health coaching. Connecting patients with peer support may also improve mental health. There's a lot of literature about the importance of choice. I think that you could legitimately make the case that people would have different preferences for how they would want to use a system like this. So that's kind of what we're thinking at this point. Some of the important limitations is that this was a pragmatic trial with no pure control group. We had control strategies for implementing the app, but if to do another efficacy trial in this population would require a sham device, and we weren't looking to do that type of study. Self-reported alcohol use was the way that we assessed. All of the coaching and peer mentoring was done remotely due to COVID. The health coaching was intended to be done in person at first, but that didn't turn out to be practical. And as noted, largely a white female population limits the generalizability potentially to other populations. So we're still in the midst of this. We're now interviewing the peer mentors and health coaches to understand their experience, as well as individuals in the health coaching group, to understand potential causes of the differential attrition, doing economic analysis, and then a number of secondary outcomes analyses, including mediation analysis to try to understand how this, what the mechanisms by which this might have worked for different types of patients. I guess I'm going to run through quickly the last presentation before going to questions. And I'll probably do this quickly. So that study is finishing up. The project that we're just now starting is looking at patients with alcohol-associated liver disease. Again, I want to acknowledge my collaborator, Linda Park, who really led this effort. We have a publication out about the pilot tests that we did for patients with alcohol-associated liver disease and JMIR formative research. And the problem here is that the rising rate of alcohol use has really increased the burden of alcohol-associated liver disease. In this case, alcohol absence is the only intervention shown to substantially reduce morbidity and mortality. But there's really not a lot of, there's a real gap in terms of treatments and interventions for alcohol use disorder for patients with alcohol-associated liver disease. Some of the options are, motivational interviewing, cognitive behavioral therapy, self-help, pharmacotherapy, digital interventions for reducing alcohol use. That's what we're kind of looking at. What we learned is that by and large, the most common advice that's given to people with alcohol-associated liver disease is to just basically go to AA and stop drinking. There's not a lot of support within the medical system for patients. That's starting to change at Wisconsin and at Michigan, which is the other site where we're doing this study. But that's sort of the norm in the field. Some of the barriers to treatment include geographic distance that, can be really difficult, especially if people are getting sick with ALD. Pharmacotherapy, there's concerns about metabolism and toxicity. And, really, as mentioned before, hepatology and addiction medicine really operate separately for the most part in practice. And so we're looking at kind of ways to try to bring those fields together. So we wanted to understand, could we use a system like HS or TULA in a population with alcohol-associated liver disease with sort of a goal of providing or setting a new standard of care for patients and clinicians caring for these patients who really are dealing with severe consequences as a result of alcohol use. So we did a mixed methods usability test in the hepatology clinic, pre and post structured interviews. We had patients use the TULA app for 30 days. That's what we had kind of available and ready to go. And we provided them incentives up to $100 to participate. So quickly, the inclusion criteria, similar in a lot of ways, but having, to the prior study, but needing to have diagnoses for both ALD and AUD, as well as alcohol use in the last 6 months. So people who weren't, in long-term recovery. We excluded people who already needed a liver transplant. This is, for people with sort of more beginning stages of alcohol-associated liver disease. And so we recruited 11 people for this pilot test, 5 males, 6 females, and other demographics listed there. We did a mixed methods quantitative and qualitative analysis, really kind of simple quantitative stuff. It was only, 11 people, so not large enough to do any kind of statistical testing. We really wanted to learn more about experiences using the system from individuals. Again, we're in this process kind of trying to integrate how does the whole health model integrate with self-determination theory. And we did use the whole health model as the basis of our approach to treating alcohol-associated liver disease, given that it is widely used in medical care settings. So, we had pretty modest goals for this. We are just trying to understand, would people with this in this population use the app? And by and large, they did. Used it for more than half an hour on the first day. And after that, about 40 minutes total over 4 weeks. We had 100% response to our weekly surveys. And that was something, there were some concerns about would people be able to be active on a system like this. We definitely found that they were. I'll talk briefly about some of the experience that people had using the app for 4 weeks. We heard things like, this is a severe health problem, a serious wake-up call. People are feeling very overwhelmed and overloaded with this type of a diagnosis, and often feel like they're swimming alone and isolated and unclear about where or how to find support. People really appreciated the weekly surveys and tracking feature think about urges and triggers. We had motivational quotes that provided some inspiration for people, and people by and large found the app easy to use, to navigate, and to utilize. We didn't really have a lot of ALD information alongside the alcohol use content, so that was something that we clearly need to add going forward. Some information about elements like nutrition. How do people need to change their diet if they have alcohol-associated liver disease? And there's a lot of interest in having a peer-to-peer discussion forum. We've heard this in a lot of different contexts, that people find it hard and uncomfortable going to AA meetings in person. So a digital kind of modality could be helpful. Again, I won't go over this in any detail because I kind of just did. But I'm going to talk about kind of where this is leading. We are now, we had done a grant submission, and part of the concern that the reviewers had was the lack of, they didn't think it was feasible to do this. So the data that we collected was very useful and helpful for us in responding to reviewer concerns about lack of feasibility. We did this feasibility test and showed that we could recruit patients, we could get them to use the app, and that was I think helped us get from a good review to an excellent review, where we got into the fundable range. This project has now been funded as of December 1st. And is a trial that we're going to be running. So we're going to be looking to recruit 300 patients starting this year with alcohol-associated liver disease, and testing the effectiveness of this system in that population, just kind of going back to straight up intervention versus control randomized clinical trial design, to test the effectiveness of this digital health system for patients with alcohol-associated liver disease. This is just the pilot test, but it is going to be scaled up in a clinical trial going forward. So I think we only have about 4 minutes left, so I wanted to close there and hopefully take time for a few questions. Thank you.
Thank you, Dr. Quanbeck. We all enjoyed that presentation, and we do have a few questions, it looks. I'm going to start with the chat from Dr. Higgins. She said, "I appreciate your talk and these health efforts. Thank you. You mentioned Alcoholics Anonymous in a very brief passing. I would love to hear more about how your efforts might complement / work in coordination with 12-step programs, given the latter success with so many, but it's almost complete siloing outside of mainstream healthcare."
Yeah, it's a great question, and I agree that it is very separate from mainstream healthcare. I think that Alcoholics Anonymous, and I don't stay on top of this, I think that they have developed something that's similar to this over time. I guess we are thinking about, sort of doing something similar to what AA does, but doing it in a way that it's a bit more, we sort of create groups of users in this alcohol associated liver disease study. We'll be creating something similar to sort of a virtual Alcoholics Anonymous, but it's going to be, what's going to be a little bit different is that the patients will be recruited through the clinics and will have their experience of alcohol-associated liver disease, and the fact that they are patients of a health system in common. So that, I think, will make them a little bit more similar in some ways than AA, which is I don't have a ton of experience, but I think is open to anybody who wants to stop in. So it's a little bit more highly selected. We have still heard that, you know, even though it's kind of tied to the healthcare system, the individuals in the system do not identify themselves by name. I mean, unless they choose to do it on their own, they use anonymous like screen names. We also operate this discussion group kind of separately from, so they're sort of tied to the healthcare system, but we don't share the data with hepatologists or, you know, other physicians who are providing clinical care. So it's kind of a you know, a place where people can feel free to share and not have to be on their guard about, you know, if they, for instance, have relapsed after a period of absence. You know, we don't want that to be a barrier to them, you know, feeling like they have a place to open up and communicate about their issues. So yeah, good question.
Thank you very much. I think that we're at time, but again, we'd like to thank you for giving grand rounds this morning to our department.
Okay, thank you for inviting me. I appreciate the opportunity.